leave it to Dr. Greaves to give her presentation.
Thank you. Thank you very much, and welcome everybody today. Um, I'm calling in today from Vancouver, where it's still early morning, on the lands of the Musqueam, Squamish, and Tsleil-Waututh nations. And the Center of Excellence for Women's Health is fundamentally based in Vancouver, but we're now a virtual research and knowledge exchange center with staff and team members across the country. So I'm very familiar with CAMH and many of your staff and leaders, and really, really happy to be here. Excuse me. This topic is, as many of you will know if you're involved in the field at all, less than straightforward. A lot of people in Canada think, oh, tobacco use, smoking, we've got that handled. The rates are going down, and they are indeed declining. That is true. At the moment, we have roughly between 10 and 13% of the Canadian population smoking cigarettes, and 11% of those, 11% of women. So you could think in comparison to a lot of other countries that we're doing very, very well. But of course, the story doesn't end there. The story is a lot more complicated than that. And so a lot of what I'm going to be talking about today, by necessity, looks at the history of tobacco use and its trends, looks at vaping and what that's got to do with the picture these days, and looks absolutely at equity issues and sex and gender included. So I'm going to start there. There's a little bit of my background is embedded here. You'll see just in my bio that I've worked in a lot of different sectors. And so I do want to talk to you about the issues and responsibilities of each of those sectors, like research and academia, as well as program and policy and practice, and what we can all do differently and together. So let's look at the agenda. I'm going to look at the patterns of use. I'm going to talk then a little bit about sex and gender related factors and tobacco and vaping, just so we're grounded in some of the emerging science. Then I'm going to spend a fair bit of time. It's really the pivot of what I want to talk about is what women say about smoking and what it means to them and how it functions in their lives. And a lot of that is about cigarette use and smoking cigarettes, but I do have some newer information from a project we're doing right now about vaping among pregnant women and postpartum women, and looking at what some of they say about the meanings. So just to bring in that vaping business a little bit, to try and compare it a little bit to what the meanings are with respect to smoking. I am going to talk about reproduction and pregnancy, and I'll tell you why. As you'll see in a minute, there was a lot of emphasis on this way back pre-1990. It was, in fact, the only way that women and tobacco was even studied or considered was through the lens of pregnancy. And it was very fetus-centric, what I came to call fetus-centric, not woman-centric. So in our talks now at the Center of Excellence and the work that we have done since then, we try very hard to widen the gaze about what pregnancy and smoking is really about. And then to look at the underlying and most pivotal aspect of what tobacco and vaping means in Canada today, and that is about an equity lens. So we're going to do these three things. We're going to look at sex-related, gender-related factors, and look at the interactions of these things with equity on both tobacco and vaping. So here's the history. In case you didn't know this, and some of you will, men began smoking first as a group, and women smoking at that point was disapproved of. And this is going back maybe almost 100 years in North America. And what this means is that smoking-related diseases, which take quite a while to develop in a body, began to emerge as medical issues around the 40s and 50s and 60s. And they were in the form of heart disease and lung cancer primarily, but they were first understood as men's diseases. And until 1990, as I just mentioned, women's smoking was only of interest through a pregnancy and fetal health lens. And so we had a very distorted view at that point, which seeped into the research, policy, and programming area. Even public information about smoking was really very much directed at men, and for women was very much directed through a clinical lens around pregnancy and fetal health. Now, around 1990, as kind of a tail end of the women's health movement in that period, people began to ask questions about why there wasn't any woman specific research, health promotion, or treatment in this area. And so began kind of a shift in how we were beginning to look at this. And what's evolved since then, what started out as a women's lens on this and a girl's lens, has now become more of a sex and gender science lens with the research. And with the program and policy aspects, more of a gender and equity lens to try and figure out what we can do better. So, what this means, though, is that the diseases and mortality and morbidity first emerged among men, and those diseases and mortality and morbidity really peaked about a generation or two later among women. So we have distinct curves of how we're seeing the impact of tobacco and vaping ultimately. Um, what's really super important now is that globally, just like we've seen within Canada, tobacco use has moved from high income countries to low income countries. And within Canada and high income countries, from high income to low income people. And in that process, we've seen a lot of targeting of not just women, actually, but also various subpopulations, LGBT populations, blue collar worker populations, subpopulations of diverse, not only women, but diverse men, in order to sell products, all done by the marketing arms of major tobacco companies. How that's manifesting in low income countries is that the production of tobacco, as some of you will know, left Canada and countries like ours. We decommissioned our tobacco farms some years ago, and it's now moved to low income countries where the manufacturing of these products takes place. Not to say, without surprise, this is also a very exploitive industry. Now, what's really interesting, though, is that globally and in Canada, the gender gap is closing among young people in the uptake of not just vaping devices, as I say here, but also cigarettes. And so that's interesting because the gap that we traditionally saw is less so now. So it's almost like we have to look at this a little bit differently. So the toll, 1.5 million women die from tobacco globally each year, and 300,000 women die from secondhand smoke. And those women are not smokers primarily. They are exposed, whether it's in the home or in the workplace. And 3/4 of these women live in low and middle income countries. So you can see for yourself that was once a huge epidemic in Canada and the US and high income countries in general has actually shifted. But with population growth, the raw numbers of people involved, pretty huge, 208 million women. If the World Health Organization reaches its target by 2025. And you can see their target is 30% of any tobacco use. That's cigarettes and vaping devices. In Canada, we have a target by 2035, 5%, but that's just about tobacco. So they're not exactly comparable, but you can see they are still quite different. But as I mentioned, we're going to have a delayed burden of disease as women age based on the shape of the epidemic that I've just described and general diffusion. So sex and gender both affect tobacco use. And this is really central for you to understand that there are biological and physiological aspects of ingesting a substance like nicotine into your body and all its additional chemicals when you're smoking cigarettes that have an impact on a female body different than a male body. Not completely, but there are distinctions. And then on the other side of the equation, there are gender related factors that have an impact on women and girls in terms of gender relations and gendered power differentials, which I'll talk about in some detail today. So, what we end up with, the bottom line is that, like many substances, the female body at lower levels of exposure or consumption, in this case, experience more damage from ingesting a particular substance. This is true with alcohol as well as nicotine. It will likely become true with cannabis as we learn more about the impact of cannabis on bodies. So this is not an unusual equation or an unusual learning, but it is something that's super important for all of you to understand, because it has a direct impact on clinical care, public information, and program development. So there are some examples there. Females are more vulnerable to lung diseases on less exposure, coronary heart disease. It's partly because metabolism affects nicotine ingestion, and that's particularly heightened during pregnancy. And we also see this in the way females and women respond to NRT, which is differentially not as well and with lower quit rates. And quitting attempts in general, you may know this from your own practice, quitting attempts in general, quitting in general is more difficult for women. So those are just, a few highlights. I will say that sex and gender science, which is, probably only now gaining traction in research circles, is behind on these matters and has yet to fully discover how sex-related factors, whether it's about female bodies or male bodies, matter in things like tobacco use, and how gender-related factors also matter, whether it's about any gender, whether it's about men, women, or gender diverse people. So the research in these areas is still really, in my view, extremely limited and behind. On the gender side, just some highlights here. I've already indicated the exposure to secondhand smoke is gendered, but you also have to see that there are gendered experiences that men and women and gender diverse people have that have an impact on whether or not they pick up tobacco use or alcohol use or any other substance use. And secondly, what it might end up meaning to them in terms of their cultural experiences or their experiences in the world. Not to mention the influence of marketing that is directed at particular subpopulations among us. So there are power issues, and there are issues around meanings, as you can see there, in terms of controlling negative emotions. So in short, there's emerging evidence about female-specific cancers, the whole fertility and pregnancy area, which we'll come back to, and of course, SHS and smoking-related diseases, all of which I've just mentioned. And on the right here, some of you may remember Barb Tarbox, who is pictured here on this cigarette package. She was a Canadian woman who died 20 years ago of lung cancer, with only an 8-month warning before her death of her impending death. And she dedicated her imagery and her messaging in her last 8 months of life to this message. So she was really trying hard to be an ambassador, especially to girls, in the work that she did. I've mentioned hormones, but there are genetic, neurobiological, and physiological aspects as well that some of you may be interested in knowing about more generally. And this little diagram is useful for thinking through what sex-related factors could include and whether or not you could apply this kind of diagram to other areas of interest for you. This gender, same thing. There are lots of aspects of gender A lot of people make the mistake of conflating the word gender with gender identity these days, but certainly gender is an ongoing and multifaceted concept that includes the gender roles, the gender relations, and the institutionalized gender that comes through in aspects of media treatment, education, government. It comes through in the way we do research. I've already alluded to it, in the way we might have policies and programs supported by the government. These days, in Canada, for example, policies and programs in tobacco are increasingly tailored to what's called priority populations by the government. So finally, we are beginning to see the institutionalized treatment of gender in a more positive way, as opposed to just ignoring gender aspects. And then, of course, all of these dimensions of diversity mesh with sex and gender, which already interact to create a myriad of experiences for people that you will know from your practice and from your research to be extraordinarily important. So, looking at this, if you're thinking about a research program or if you're thinking about practice, you realize immediately not only do you need to take into account sex and gender related factors, and I'm not talking about sex and gender as categories, that's too simplistic here, but also all these other possible experiences and overlaps that people may be experiencing that have an impact on what goes on in their lives. So, low income or homelessness, for example, their sexual orientation, um, whether or not you're in an Indigenous community, all of these things will make a difference to how you experience tobacco use. So you can see, just thinking about it, gender roles, whether or not you're in particular cultural contexts, whether or not you're in the domestic sphere, gender relations, whether or not you're actually interacting, especially with other genders, makes a difference as to how you experience substance use. And certainly, couples have definite interactive patterns around issues such as smoking. We've done a fair bit of research on this at UBC under Joan Batorf's leadership and John Olive. And we've been part of those teams for years, looking at the interactions between heterosexual couples and smoking reduction issues. So, adding all of this together and coming back to women in particular, you need to be aware of things like the overlaps of violence and assault, caregiving burdens and stress, low income and poverty. We know there's a wage gap in Canada still that is quite significant, and therefore you're going to see the impact of that among the people that you deal with. Coming with that are stress and depression issues, and certainly peer dynamics and neighborhoods. We all know in any public health issue that context and neighborhood and setting has a huge impact on what goes on. Just a little bit more about trauma and from girls and women's perspective. Adverse childhood experiences affect men and women and essentially are linked to substance use in general, smoking included. But more specifically for women, it says intimate partner violence. If you've experienced that or are experiencing that, there's a much higher rate of smoking. So, when you think about the rate of the general population in Canada is about 13%, 11% for women. And you look at some rates such as 58% among this particular subgroup, that should point you to particular challenges in dealing with that particular subgroup with respect to smoking. Sexual assault, similarly, and PTSD, and among girls in poverty, even higher. So this brings me to the pivot of what I want to talk about today, and that is something that I've been researching for a very long time. This particular book, Women Smoking and Social Control, is a rendition of a lot of interviews and group interviews I did with women in Australia and in Canada, women who were self-described feminists, women who were living in women's shelters, women who were in Indigenous communities, and all of these women's testimony was brought together in this book. And, very, very briefly, I just want to tell you a little bit about what they said. Um, they said that women in general said that smoking was very important to them. It had become very functional in their lives. They were using it to adapt to certain circumstances. And so, in so many ways, we have to begin to understand that smoking is adaptive. It's a way of coping. And the specifics around this were about organizing social relations. Women had very interesting descriptions of this. It allowed them to feel more easy in social contexts. It allowed them to diffuse conflict in gendered, especially couple relationships. It allowed them to make friends, keep friends, to have linkages with people. The business about controlling emotions also, this has been found in a lot of research that not just with smoking, but with other substance use as well, that the idea of suppressing negative emotions is a big reason for women's usage of things like nicotine or alcohol. And this is different from what we read about with men, where it might be more an expression of positive emotions, of pleasant emotions. So we actually hear from women that they are, quote, sucking back anger with each cigarette. It's a way of not expressing what they really feel. Creating an image, this you can see as a direct line to the fashion and advertising and marketing trends surrounding tobacco, but also what comes through in movies and fashion. And then dependency. This is an aspect of the emotionality of it. I've had more than one women say to me, cigarettes are their best friends. And, that's worth pausing about, because if that's true, I think what that says is much more about our societal role in terms of making sure as a society we deal with people's needs than it does about that woman. And solace and crutches. And then identity formation. A lot of the smokers that I have talked to started when they were teenagers. And that meant that a lot of what's associated with smoking, cigarettes in particular, is about their identity formation, social cohesion, the way they made friends, keep friends, and so on. So I've summarized a lot of material there. We did similar work with Indigenous adolescent girls in 6 communities in BC a few years back. And they talked about relational and peer pressures. They also talked about stress and the pressures on them as girls to do what they saw as more caregiving than boys in their communities. Not to mention, as girls in the communities, they saw a lot of co-use with alcohol and cannabis, and experienced boredom and partying, opportunities where smoking played a big part. And a lot of these girls were beginning to smoke at very young ages. The maternal role models, which I haven't mentioned, were pretty important in that context. So, just a few words about reproduction. We've done a fair bit of work, including Expecting to Quit, this book on the right that some of you may have used in the past, which was best practices in cessation during pregnancy and postpartum. But we see reproduction as much bigger than that. We think it involves both sexes, all genders, and is a preconception planning opportunity for public health and for nursing and for physicians who meet with people to say, what are your reproductive plans and how does substance use fit into that, specifically smoking? When pregnancy occurs, as I've mentioned, we've tried to shift the gaze from fetus centricity to women centricity. And what you may or may not know is that there is a fair bit of spontaneous quitting during pregnancy, but that the relapse rates are extraordinarily high in the postpartum, upwards of 50 to 80%, depending on the research that you read. So essentially, what we tried to address in the Expecting to Quit book was the notion that quitting during pregnancy was temporary abstinence, as opposed to a woman centered shift into a better health pattern. Um, what we have added to the reproductive cycle is the issue of parenting. And that brings in the middle thing about STARS, which was developed by Aware in Kingston, Ontario, which was a program for harm reduction for low income mothers who smoke to try and interest them in how they could reduce the harm and impact of secondhand smoke on their infants and children. Now, we've since extended this notion about harm reduction in parenting to men as well. It's not the focus of what I'm talking about here today, but this is a real opportunity to engage men as fathers and anybody who is contemplating or has contemplating children or has custody of children or has care for children to begin to think about how their particular health choices around substance use and smoking in particular fit into that. So, the reason I saw this as a pivot today is that where we go with this material, how do we translate these meanings and dynamics of smoking and vaping into action? And there's just an article I wrote a while back where you can read about that particular link. But I just want to go in for a minute into the vaping research that we're doing at the moment. When we talk to pregnant women and postpartum women who vape, um, first of all, you must understand that we had to ask them what they vape. We found that they vape nicotine, about 25% of them, about 25% are vaping cannabis, and about 50% are vaping both. So that's question one if you are actually in a clinical role. Vaping is an action, it's not a substance, so do remember that. But basically, the pregnant women in particular were finding that stigma reduction, and even the new mothers, stigma reduction was crucial. It allowed them to be more discreet about taking in nicotine. They didn't want judgment, they didn't want intervention from strangers in public. And that was a big motivator. Um, a systematic review of vaping in pregnancy, not about our surveys or our qualitative interviews with women, but in general. This is of the literature. It's still very nascent, this area, in terms of research. We don't have a full handle on it. We do know that in Canada, vaping the rates of vaping exceed the rates of smoking among 20 to 24-year-olds. And in particular, 23% of 20 to 24-year-olds vape in Canada, and 20% of those are women. So what that means is, 17% of those are women. So what that means is that vaping devices are overtaking in that age group cigarettes. And so when you think about pregnancy, that's really super important because what we've been able to determine over the years is that pregnancy and nicotine is essentially a young women's issue. And yet, a lot of our programs and policies and interventions do not take a youth framed approach to this issue. So that was a bit of an aside, but just to let you know that vaping in general and vaping in pregnancy is something that we've got our eye on, obviously. Um, Among smokers, existing smokers, vaping is, as you would expect, much higher. And dual use, which is something we are all dead set against, is also extremely high at 15%. And that's because we feel like dual use is the worst of both worlds. So, as I mentioned, we have a dearth of information in this zone. We need to step it up. So, if you're a researcher, this is an area to dive into immediately. We do know that vaping is increasing during pregnancy. We don't have a handle on exactly what is being vaped, in what quantities, using what devices. That is all still very, very hard to measure in research. But we do know that vaping cannabis is popular during pregnancy as a route of administration. And, more than anything, I want to draw attention to the general advice worldwide is that vaping anything or smoking anything during pregnancy is not recommended. It's a bad idea. But that doesn't change the reality of what is going on. So we do need to attend to the harm reduction aspects of this and figure out whether or not we can come to some interactive, and I'll be coming to what I mean by that interactive relationship with, in the clinical setting in particular, or in the group setting in public health, that is going to be productive. So, bottom line here is that sex, gender, and equity mixed together to sort of distribute who's smoking. And this slide is about cigarettes. But you can see, even though this is old, the shape of these bars is still really important. The bottom, you have Canadian street youth. Above that, First Nations and Inuit. And we have some of the highest rates of smoking in the world amongst First Nations and Inuit people in certain community surveys, and certainly among street and homeless people. You see just above that LGBT, that remains true. People with low income, people with a disability who've been super overlooked in the smoking field. And I think that's an important thing to begin to change, and so on. So you can see, if you just looked at equity, you'd see bar graphs, bars like this. If you then introduce sex and gender into this, you begin to be able to divide that up. So what do we do about this? We have done a lot of work with the Alberta Health Services in developing their reproductive uh, health approach, especially to tobacco, and develop these principles with them and for them. And I think they're worth absorbing because it sort of summarizes a lot of what I've spoken about and a lot of where we could go from here. We need to be women centered or person centered, depending on who you're dealing with, and and really respect context, pressures, and goals. You can see by some of the things I've told you already that our goals as healthcare providers or researchers or policymakers are different, going to be very different from the groups we're going to be dealing with on this issue in Canada today. That experiences, life experiences, are going to press in on people and on groups of people and make a big difference to how they react to advice. Harm reduction. It took ages for harm reduction to be accepted in tobacco control, but I would say it now is. And this is something that we can take advantage of in designing policies and programs to reduce the health impact of tobacco use and improve other things along the way. This is essentially a story in Canada now about the social determinants of health and other kinds of pressures, such as living with violence, living with poverty, living with homelessness, living with discrimination. And if we don't address those kinds of pressures, then some of these individuals and groups will continue to adapt and cope in ways that are less healthy than others. But this also means that we can address some of these pressures through housing policies and food policies and anti-violence policies and anti-stigma education among healthcare practitioners. Equity informed goes without saying in everything that I've been discussing, and trauma informed, which again has not been a feature of tobacco control originally, but now is gaining some traction and is something that, if you're not schooled up on trauma informed practice, it's worth doing that because it will inform not just policy, not just programming and clinical care, but also policy work. So there are some standard approaches. We did some further work on adapting the 5 Rs, and I'll show you that diagram in a minute, with the Alberta Health Services, but also we push a lot of motivational interviewing as well as TIP, trauma-informed practice. But fundamentally, these are the things that we can all do. We can get some evidence that is sex, gender, and equity specific. And by that, I mean we can actually seek out and inform ourselves. And this applies to all of us. This applies when we work directly with women in groups, or when we consult with women in groups who might use our materials at the Center of Excellence. We start here. And interestingly, there is a hunger among groups of women we deal with for sex and gender specific information. I think all of us now realize this has been missing often, and it is the place to start. So don't presume that women and others don't want this. They do. When we interviewed women who vape in pregnancy, the amount of research that they had done on their own to try and find evidence was impressive. And there was a lot of agency involved. And it's because there's a vacuum amongst all of us working in public health and sex and gender science and policy. And then a trauma informed approach, the SDOH, the social determinants of health, integrating harm reduction, all the things that I've mentioned. This is the kind of information that we create all the time. This is literally a one pager. And by the way, all of these resources I'm speaking about today are available on our website, cewh.ce, and you'll see that at the end. This particular one is being revised right now and will be re-released in April to include vaping, because now we talk about nicotine, cigarettes, and vaping all in one, as is required. But this is the kind of one pager that women download, clinicians download as a starting point. Then when you get into practice options, it is possible to create respectful discussions that adapt some of the 5A approaches. And you know, if you just look at a couple of things, you start by asking, what do you already know? What have you already done? How are you negotiating stigma? Acknowledging the influences in her life on her use. All of those things, and these you could apply to things other than nicotine and vaping, obviously. But these are ways to set the stage that allow for motivational interviewing to take place and trauma informed practice to happen and strengths based work to be developed. And then it's really reflecting on the changes already made, maybe taking it one step further, assessing readiness. And that point, at step 3, you begin to record data. Not like in the old days where we would start there, which is a bit off-putting. And then assisting with changes, reinforcement of strengths-based approaches, and arranging for referrals. And those referrals are things that are way wider than tobacco use. They get into other agencies, other services. These are, to some extent, part of the motivational multi-component approach that we push in so many areas. We deal with cannabis, meth, alcohol, tobacco, opioids, and we try and integrate the same principles, acknowledging the idea of trauma and social justice, along with reflecting on the meanings when we know the research on these things and supporting changes. And this allows for this kind of conversation. We have a number of booklets called Doorways to Conversation, which outline these basic principles about strengths-based work and women's participation. So you're co-developing work and entering into treatment as a web of relationships and peer and professional support, not kind of a one-down thing. And this is one of our most used booklets, which is really an MI or motivational interviewing based handbook aimed at providers, but read by women and providers. And it really does take you on a journey. It even offers scripts for providers to use that are motivational interviewing type scripts that are about strengths-based, that are about reinforcement of minor changes, and that are about developing this respectful, equal, balanced relationship. One of the things I want to highlight here, which comes from my own work, when I have interviewed women and do interview women still today about smoking or now vaping, I always end with a question about how would your life have to change for you to become a non-smoker? And that is a very interesting and profound question I have learned, and I would highly recommend it because essentially, when you see that smoking and vaping can actually support identity formation, it stands to reason that if you're asking somebody to think about giving up the identity of a smoker for a non smoker, they're going to have to shift a lot of the things in their lives and a lot of the principles in their lives. So here we have some questions to pose. What would that be? What would you gain or lose? What would get in the way? What do you need? And who can help? And this, this kind of embedding of these kinds of open ended questions is an excellent place to start. We've got a conversation starter that came out quite recently on vaping during pregnancy that embeds some of the things I've spoken about today. Um, and here are, just as a final slide, some of our resources. You can pick these up on our website, they're all there, and other things for that matter, plus the journal articles, some of the journal articles we've written on these matters. And that website is here, cwh.ca. So thank you so much. Rachel, over to you.
Yeah, thank you, Dr. Greaves. That was very engaging and informative. So, yeah, thank you for that. Now we're at the point where if anyone does have any questions, they can post them in the chat for Dr. Greaves to answer. Oh, so Rachel just wanted to know what the website was. I can go back to this slide. So www.cewh.ca. So Emil or Joyce was asking if you have any recommendations for smoking cessation CBT for pregnant women.
Well, CBT does have evidence for working with pregnant women, but also the questions about introducing NRT as well are out there. And definitely harm reduction and relapse prevention factor into that. So in that Expecting to Quit book, a lot of these things are covered with respect to cigarettes, not vaping. Um, and there is a real mix of official policy and program recommendations and research recommendations on pregnancy and nicotine in general, with the USA really being against introducing nicotine as part of a treatment in pregnancy. Um, the UK suggesting vaping to pregnant women as advice and encouraging clinicians to do that. And in Canada, we're sort of in between. I think in Canada, with the new guidelines done by CAMH, we kind of recommending or realizing that the evidence is emerging well enough to support the notion that vaping is safer than smoking. However, in the pregnancy and postpartum department, we have very little research on which to go on. So that's kind of what I was getting at earlier, that there's really a dearth of research on vaping and pregnancy. There is more research obviously, on pregnancy and smoking. And some of the treatment approaches um, have been debated in the literature for a long time, and they do include NRT and CBT. I think, though, just my last comment on all of that, what we have to realize now is that vaping is in the mix, as I indicated, and that certainly the characteristics of the populations that we are dealing with in pregnancy and outside of pregnancy and smoking and vaping these days in treatment populations are much more complex than when we started this work in tobacco control.
Great, thanks. And then Jessica wanted to know if or what recommendations you have for larger scale smoking or vaping cessation or prevention interventions targeting women populations beyond things that healthcare practitioners can do.
Well, that's a great question. You've probably seen that this is really a question of equity. In Canada, this is really about an equity and health problem. It took a very long time for governments and clinicians and researchers to grasp that in tobacco control, which has been a problem because we lost a lot of time. But what that means now is that we have to deal with prevention and cessation and policy for that matter, but prevention and cessation programming in a very different way. I'll just give you an example. I mean, the scope is huge for this. It's really limited only by your imagination. It could mean that we need different ways of delivering. We're currently doing an intervention research project, for example, where we're looking at women who have both used alcohol and tobacco and have experienced intimate partner violence. And we're creating virtual social support group intervention as a way of improving the health on both of those accounts. So there's one example, but as you can see, the sky's the limit. And once we scale that up, that will be available publicly in a few years. We're just about to pilot that. Um, you know, Issues around tobacco prevention and cessation without getting involved in another related issue like IPV really now have to focus on what the government calls priority populations. Who are these populations? How micro do we get in our lens? What do we understand about what their existing settings and contexts and issues are? And how do we intervene on that? And that means we have to work a lot differently in terms of creating prevention and treatment with groups who are affected, with people who have those experiences. And I'd say the sky's the limit. I think we need to develop tobacco control that comes not from agencies in tobacco, but from agencies in the social development sphere, whether that be homeless shelters or whether that be women's shelters or whether that be poverty organizations or food banks. We need to be integrating our prevention and cessation into a lot of different avenues. I said earlier that one of the things we're beginning to look at is the whole disability zone. A lot of people have sort of overlooked that group of people in Canada, but they do show up on surveys as having, higher rates of use of tobacco. So that's an area where we could perhaps intervene and develop programming through a different doorway in general. So the work we've done on pregnancy has gone through different doorways. We go through POP programs, pregnancy outreach programs. We go through, neighborhood and community group settings or community health centers um, or community centers in general to try and reach populations differently. So I'm not giving you a single answer to that question because it is the fundamental question that we're struggling with generally in Canada. How do we do this more effectively to reach that 5% by 2035 goal?
Great. And we had another on any thought on nicotine pouches,
Ah,
Exonic for cessation of pregnancy.
well, these are a new thing, as you've all been reading, and I think it's another example where policy in this country is well behind and hasn't been ahead of the game, is behind the game. So, if you didn't hear CBC yesterday morning or the morning before on the current, I encourage you to go and listen to that, where my colleague Dave Hammond was speaking about pouches. Essentially, similar problems that we've had with policy on vaping. We've created, as you probably could deduce from the statistics I gave you earlier about vaping, we've created a new problem among young people because our policies in Canada were not effective in restricting vaping devices from young people. So we now have a group of young people in Canada who will now have to struggle to get rid of vaping in their lives, or may in fact switch to tobacco or both, which is worse, as kind of a whole new group. The same could happen with pouches, unless the regulation of those things is really reined in. I think what you have to realize is that in both cases, with vaping devices and pouches, the industry is creating brand new products here and overseas, multiple new products, in order to retain a market of people addicted to nicotine. They say, like Philip Morris says officially, they want to see people stop smoking cigarettes. But what they're making sure of is that people still use nicotine. And so keep that distinction clear in your mind. They want to say to us that they're marketing pouches and vaping devices as cessation devices only. And if that is the case, then they should, in my view, be regulated, prescribed by practitioners, and available only in pharmacies. But that is nowhere near where we are yet.
And then one last question, do you have any suggestions for resources that offer presentations or workshops on this topic for the community?
Presentations are, well, you may find some on our website, but I would say CAMH probably has lots. And there are training modules. So I would think between CAMH and the Center of Excellence for Women's Health in Canada, we probably are the ones who do the most on this specific topic. And there are training modules in both zones and in both websites. So there's lots of work going on in Canada at those two institutions.
Thank you. So yeah, again, just conscious of time. I know we're approaching the end of our hour. So if anyone has any additional questions or wants to reach out to Dr. Greaves about anything, you can see her email right here. And so yeah, please feel free to reach out about that. So if anyone has to go, that is okay at this point. Thank you for coming. I'm just gonna carry on with a couple more housekeeping items to end it off. Oh, and then just a reminder, we have CAMH is with Women Mind testing a woman-specific app for smoking cessation and are currently looking for participants. So these are participants who would be women between the ages of 25 and 65, smoking at least 5 cigarettes per day, and who own a smartphone with internet access. So if anyone is interested or knows anyone that could participate, you could reach out to the email below on the slide. I will also note that we will be sending out a poster and contact information along with the recording and slides to all attendees. So you'll be able to access it through that as well. And so just a reminder that if you are interested in receiving a letter of completion just to complete the post-learning assessment, that will be sent by email by the end of tomorrow. Yes, and then our next Teach Educational rounds will be in January, and we'll have more information on that coming out soon for registration. And if you want to watch this webinar again or review another webinar, a list can be found on the Teach website. And so that's it. Thank you so much, everyone, for coming out, and thank you, Dr. Greaves. I hope everyone enjoys the rest of their day.
Thank you, Rachel.
Thanks, Dr. Greaves.